So now you know you're being recorded, or at the moment I'm being recorded. Welcome to one of our international seminars, which we used to call International Breakfast Seminars, and for people in the UK, probably is your breakfast time, but we know that we'll have people from other parts of the world where it's long past breakfast time or not yet arrived. I'm Christine Hancock from C3 Collaborating for Health, and we're delighted to be working with the George Institute on our current series of seminars. So we started these international seminars some years ago. They used, of course, to be virtual ones. We were famous for our healthy breakfasts, but they were more complicated in that we had to find people coming through London. And of course, we could only reach the number of people that our room could hold. Like most people, forced online by COVID. We've actually realized there are great advantages for us in this, in that we don't have to wait for people to be passing through London and capture them. And also we can reach a much, much wider audience. So we've happily stayed online, except I know that for many people, that missing that opportunity of chatting in person is important. But today, we're delighted to have a seminar that originates in southern India, although I think our speakers are actually hiding in Oxford at the moment, but they'll tell you more. C3 Collaborating for Health is a small charity headquartered in London but working globally, and our mission is ending the impact of preventable illness and early death, and in particular NCDs, non-communicable diseases, chronic diseases. And we know that these are not just diseases of middle age, and indeed in many ways, the beginning of the risks for chronic disease begins at birth or even earlier. And that's why today's presentation is so relevant and so interesting. I think in the UK, like many so-called first countries, there's often a resistance to thinking that people in very different circumstances can actually teach us things. And I think that's true for many countries. And yet our experience is the innovation, the stimulation of ideas, the wow factor that comes from hearing about something in a very different place can often have a big impact on our own practice and our own thinking. So no more from me. We are recording. Please leave your camera on if you wish, but take your sound off. And I know that Jane and Nicole will want to leave plenty of time for comment, for questions. So please put those in the chat box as we go along, and we'll invite people to have a conversation, some questions at the end. But in the beginning, Jane, we're delighted that you're here and able to talk to us about the work you've been doing in rural India, which I think is really interesting for everybody. So over to you now.
Thank you, Christine. You can hear me okay?
Yep.
Brilliant. So yeah, thank you for this opportunity to present about the work which we've been doing in India with partners there this morning. It's really an honor, and I think, as Christine says, fits very nicely into the remit of C3 and this idea of how can we better prevent morbidity and mortality from non-communicable diseases. So my name's Jane. I'm an obstetrician gynecologist by training, but I spend a lot of my time now thinking about research, and particularly research affecting women around the world. So what I'm going to discuss today is I'm going to briefly talk about what the problem is, briefly talk about a solution that we might have called the SMARThealth program, and then about how we're developing and testing a new intervention, and then some concluding thoughts. So as a lot of people in this audience will be aware, non-communicable diseases are the leading causes of death and disability for women around the world. And when we look at a big country like India, we actually see a big change in the last 2 decades of this, these trends, with ischemic heart disease increasing, a large proportion of the population having undiagnosed hypertension, which is estimated, you can see there's at 18.69% in women in the reproductive age range. And the age at which people have their first heart attack in India is about 10 years younger than it tends to be in European countries and high-income countries, is about 53 years. And on top of this, we have sort of a rising tide of diabetes. India is known as the diabetes capital of the world. And really rates in adults are very high. And this graph here just shows how this has changed over time, that it's really going up. So where does pregnancy fit in with this? Well, as an obstetrician, I'm used to dealing with, when I say dealing, managing and helping women who have high risk pregnancy conditions. And the 2 most common high risk pregnancy conditions globally are gestational diabetes and hypertensive disorders of pregnancy, which covers things like preeclampsia, which you might have heard of. What most people are not aware of, though, is that if you develop these conditions, it puts you in a really high-risk group within the immediate years after birth to develop type 2 diabetes after gestational diabetes, within Indian populations up to 1 in 2 women developing this within 5 years. And if you get a preeclampsia or a hypertensive disorder of pregnancy, you've got about a 1 in 3 chance of having chronic hypertension within that immediate period. And of course, these 2 conditions are the major risk factors for premature death and disability from cardiovascular diseases like stroke and heart disease and kidney disease. So our work is really saying, well, can we break this link? Can we use pregnancy to improve lifelong health? So how do pregnancy conditions affect cardiovascular risk? Is it simply unmasking people who had were bound to get cardiovascular disease in the first place, or is it something specific with those conditions in pregnancy? Well, there's a lot of debate actually about that. And the current paradigm of thinking is often shown with this diagram here, where you can see the black line is women who don't develop a high-risk pregnancy, and they sort of trundle along, and they might have their pregnancies and nothing much happens. And then eventually, when they're much older, they might develop, let's say, hypertension in this case. That might be in their, say, 60s or something like that. As opposed to the red line, which is a woman who develops hypertension in pregnancy, here represented by the 2 peaks, which are 2 pregnancies. And you can see that she started at slightly elevated risk before birth, although that risk was well below the threshold for treatment. Pregnancy unmasked that she had this predisposition. But the thing that I want to emphasize here is after she had her first baby, she didn't return to her baseline risk. So something did happen in the pregnancy that sort of pushed the whole situation along. And then she crosses the line for threshold for disease a lot earlier than her counterpart who didn't have hypertension. So what's the situation with these conditions in India? We know they're common. So about 10% or 1 in 10 women will develop a hypertensive disorder of pregnancy. And gestational diabetes rates are very variable. And this is partly because of differences in how it's screened for and tested. But in some areas, there seems to be not a lot, and in other areas, it seems to be, almost up to 18% of women. And this map here of India shows sort of the distribution of the darker colours being the states with more gestational diabetes according to national surveys. So how can we prevent future disease after birth? If we know that this exists, what can we actually do? And this brings up the question is there a role for postnatal screening? And what we know most about in this area comes from high-income countries like the UK, and the most well-researched area is this association of type 2 diabetes following gestational diabetes. And so in the UK, our NICE guidance has a recommendation that all women should be screened, within the first sort of 6 to 12 weeks after they've had their baby, and then annually from then on for the development of type 2 diabetes. And we know here, where we have a relatively well-resourced system, that it ranges between 30 to 70% of women who get that first screen. And then when you look at subsequent screens after that, the numbers just fall off a cliff. And basically, the screening program is not well implemented. And I'm not singling out the UK as being particularly bad here. This is the same situation in the US, in Australia, in many places. And the other sort of thing, you know, I'm talking about long-term future disease here, but of course, you know, women, you know, who are in their 20s or whatever might not be so concerned about what happens to them when they're 55 or 60, but what they might be concerned about is preventing complications in their next pregnancy. So particularly women who are going to have another baby, it is very important that we follow them up after birth. So what happens during postnatal care currently around the world, so not his focusing specifically on the UK, well, I think we all realize in maternity care that postnatal care has been severely neglected for a long time, and it is, dare I say, an evidence-free zone for a lot of things. And in fact, most of the evidence we have here is around caring for the newborn, and there have been some good steps forward in that area. I thought it was a little bit depressing, I think, in a way, that the most recent WHO guideline here, whilst there was 63 recommendations of what should be done for postnatal care, none of them considered the longer term health of the mother after a high risk pregnancy. And so we really, and the reason for that is probably because of this lack of good quality evidence on how to do it effectively and affordably. So coming back to where we're working in India, what happens in India? Well, India, if anyone on the call is from India or has worked there, has actually made incredible strides in maternal care over the last sort of 20 years or so. And their maternal mortality ratio, which is the number of maternal deaths per 100,000 live births, has sort of dropped, you know, from 384 to 103. So that's really impressive gains. Compare that though, put it in context, you know, the UK ratio currently is about 10 per 100,000 births. So still, you know, the rate is 10 times what it is here, which implies that there is still more work to be done. What this big figure though hides is obviously the variation across the country and how equitable those gains have been. And we know that gaps in healthcare remain, you know, and I've listed some of them there. How has India achieved this huge reduction? Well, they've had a number of very high profile government programs at the state and national level. And I've got a picture here, which I think, coming from a Australian/UK background, I thought was quite, you know, impressive. So this is in Telangana state where we work. Every woman who delivers in a public facility gets this suitcase, and it has a picture of the Chief Minister on there, which is a very Indian thing to do. But within that suitcase, she gets a whole lot of goodies, including, you can see a lovely baby bed with mosquito net. She gets soap, she gets nappies, she gets a sari, and she also gets a cash transfer, which is a little bit more if she delivers a girl compared to a boy because of reasons of sex choice. So coming on to where we're working and how can we help bridge this gap in care. I was approached a few years ago by the SMARThealth team working at the George Institute, who were wondering whether SMARThealth could help bridge this gap. So what is SMARThealth? SMARThealth it stands for the Systematic Medical Appraisal, Referral and Treatment Program, developed by the George Institute for Global Health around 10 years ago. And the aim of it is to improve cardiovascular risk screening for adults living in rural communities. And subsequently, it's also been applied for other things: diabetes, TB, HIV, mental health. And that the concept of it is that community health workers and doctors are trained to use digital tools and point of care testing to strengthen the delivery of guideline-based care. So everything that's done is sort of enhancing what already should be happening, but is, you know, for a number of reasons, there are gaps in care. So what does it look like? Well, here's an ASHA worker in the red sari here assessing a patient for her blood pressure. She enters the number into the app, which you can see some screenshots here, and the app will give a risk indicator, which, you know, is very visual, and she can show to the patient and refer to primary care for medication and treatment, and then importantly follow it up. And the key points of it are: it was designed with users, consumers and providers at front of mind. So there's a lot of co-design in it. All components and processes are based on the best available evidence and local guidelines. and it's designed to be affordable within the communities where it hopes to be offered. So we took this, but then we have to sort of think about, well, how do you then make it something that's suitable for this population? And for those of you who are not in the academic world, we often, like to think of frameworks and things. And at the time we were using this, this is the MRC framework for how do we develop actually a complex intervention. And I won't go through this in detail, but just to say that, we first of all went through a period of development. So we had to think, what's out there? So we did some literature reviews and tried to speak to some people to understand the evidence. We then ran some stakeholder engagement events, both at high-level national events, where you can see a picture there of the panel, but also more local events to try and find out, what do people know about these conditions? What are they seeing sort of on the ground? And there's a link there to the report that we did. So what came out of all this stakeholder engagement and the literature review, to sum it up very quickly, obviously a lot of things came out, but there was a realization that we needed to shift from just focusing on women's health as reproductive health to a life course approach. There was support to identify and manage high-risk pregnancies after birth and promote, if we're going to use digital systems, they need to be intraoperative with other digital systems, intuitive, reliable, secure, and ultimately reduce the workload and administrative burden on the frontline workers themselves, which I think all of us in healthcare would agree. The other thing that came out, which we weren't quite expecting, was that everyone said, well, so okay, diabetes and hypertension, important, yes, but actually the biggest problem that we have is anemia still in pregnancy. And this really leads to a lot of problems, putting women at high risk when they deliver their babies, but also affecting women's energy levels and their ability to breastfeed and care for their babies and things afterwards. And so we suddenly realized that if we're going to do something that's going to be truly reflective of the need of what people want to do, we would also have to focus on anemia. And anemia is something that's a chronic problem in India. It's estimated around 50% of Indian women are anemic in pregnancy, according to the National Family Health Survey there. And this is despite a long history of programs to reduce this. And the reasons I've listed there. This picture of the join the dots is also from Telangana State, and this is, they actually get the community health workers to do what's called DOTS, which is directly observes therapy for iron tablets for pregnant women. And the idea is that every time the woman gets a tablet, she's meant to join the next dot on the picture, which no great, prizes for guessing what it is. But these are some of the health behavior change things that they've looked at. So we developed Smart Health with this in mind. And what does it actually look like? Well, first of all, Smart Health involves registration by the community health worker, known as ushers, of the pregnant woman on a tablet app. So we know how many people are pregnant. She did, then I say she because they are women in who we're working with, that she does the screening for high-risk conditions such as blood pressure, anemia, and diabetes in the woman's home or in a sub-center in her village. This is entered into an app. The app displays a risk. And then if needed, the woman is referred to the primary care center for review by a nurse midwife or doctor. And the doctor then has a tablet app themselves, which can make sure that they, provide care according to local Indian guidelines. And this is also through the electronic system referred back to the ASHA for ongoing follow-up. And uniquely, I think our program doesn't just focus on the antenatal period and the 6 weeks postpartum, but we're actually in the evaluation phase where we are now, evaluating the ability of this screening to happen up to 1 year after birth. In an ideal world, it would be lifelong, but obviously we have, constraints as to what we can do with our budget and our time. Okay, so what does it look like? Here's some of the screenshots here. It's very, okay, it's not the most sexy looking app, but it's very straightforward to use. It's obviously in the local languages for the people on the ground in Telugu and Hindi, but here's the English version here. And so here's the registration page. And here's what it looks like in practice. So here's an ASHA worker entering some data into the app with a pregnant woman. So the basic details. And we train the ASHA workers to how to take blood pressure correctly so that the cuff is kind of roughly at the level of the heart and the woman is sitting comfortably with her feet on the ground. And this is then entered into the app and told whether it's high or low. We also train them on how to do point of care testing for hemoglobin. And then this number is entered into the app, and we provide the equipment for that. And at the end of the assessment, a sort of screen comes up which says what the recommendations are. Obviously, red means something needs to be done, and green means it's okay for this particular patient. These examples are not the true data. These are mock-up data that you're seeing here. So these are not individual people's information. So then once we developed the app, we then moved on to the feasibility and pilot testing. And so this is important just to check that, could this work in practice? And what we did is we did a feasibility little pilot trial from 2019 to 2020. And this was in Guntur district in Andhra Pradesh and Jajja district in Haryana. So a state in the south and a state in the north. And this was really deliberately chosen. So we had very different cultural sort of situations and socioeconomic situations in both these regions. And with the idea that, if we showed that it was feasible in very different settings, this would be more encouraging to take this intervention forward. And so we recruited 200 women from 4 primary healthcare centres, and they were recruited before 28 weeks of pregnancy. And because this was only a short pilot study, they were followed to 6 weeks post-birth. And they had screening on 4 occasions using the system, sort of 2 during pregnancy and 2 after birth. And what did we show? Well, despite the fact that our study was a little bit disrupted at the end by COVID, as many clinical research projects were, we still found the intervention was very acceptable and feasible, as demonstrated by continued engagement with using the system, but also through qualitative interviews and things. But what we did find is in these rural communities that the rates of gestational diabetes and hypertension were actually a bit lower than we had expected. So 4% overall were affected by these conditions. This is not insignificant, but it was a bit lower than we had anticipated. But what we did find was anemia was much higher than what we thought it was going to be. So you can see here from this table that the number of women with no anemia overall was sort of really quite small. Sort of 78% of the population had some degree of anemia in this group, and some of these, importantly, severe anemia, moderate anemia. These are the women who are likely to get into strife. So where are we now? We're at the next phase of our framework here, and where we've moved on to evaluation. So the next phase, I guess, in seeing whether something works, because we know, people like it, it's feasible, acceptable, but the big question is, but does it make a difference? Does it work? Is it effective at doing what it purports to do? And also, is it effective for who, where, why, those sort of bigger questions. So I was fortunate to get funding to support us to evaluate this intervention in a trial. And we're doing what's called a cluster randomized trial, which means that rather than individually randomizing women to get the SMARThealth or not, we thought that'd be a bit confusing, because it's actually something that requires a health system change, requiring the ASHA workers and the PHC doctors and other things. So it's really done at the primary health care centre level as the randomization. So we have 30 primary healthcare centres. Each primary healthcare centre is responsible for a population of around 30 to 50,000 people. So, this is actually the population coverage is very large here. And 50-50, they've been randomized to either get the intervention or get a version of usual care, which I'll describe. And we've trained 240 community health workers, and we're aiming to recruit 3,400 women and follow them up for a year after birth. For those of you who know your Indian geography, you'll see we've moved from Andhra Pradesh, which is on the coast in southern India, to Telangana state, which is sort of more inland in India, but we're still working in Haryana there. And our primary research question is, can this intervention improve women's health in the year after birth? Specifically, can we decrease the prevalence of anemia in these communities by 9%? And can we improve follow-up after a pregnancy affected by diabetes or hypertension? So what the intervention clusters are getting, there's sort of 5 components to this intervention. So you can imagine there's a lot of moving parts going on here. Crucially, we have a health worker education program first up. So we need to, educate the community health workers, not just about the high risk conditions, but also about how to do the screening test. So this is a picture from one of the trainings, learning how to do a finger prick test, and also how to use the app and how it fits in. There is then obviously the core part of the intervention, the assessments using the SMARThealth Pregnancy app through pregnancy and up to 1 year after birth. And then also complementing this is we have a digital dashboard for the primary healthcare centres, so they can improve patient follow-up and sort of track what's happening in their local area. And we also track things that are important, thinking beyond just, screening is one thing, but you have to actually have the stuff to be able to treat people if they do turn up to have hypertension or anemia. And so we also monitor supply chains for essential medications that would be needed, such as iron tablets, and equipment such as the little lancets to do the finger prick testing, those sort of things. And crucially, I guess, as a sort of umbrella over all of this is ongoing stakeholder engagement and community events. So really, this has to be something that is needed and wanted by the population where we're working, rather than us as sort of a foreign research group coming in and saying, you guys should use this. So really, there's a lot of effort done to try and keep those relationships and listen to feedback from the community. What happens in the places that don't get the intervention? Well, I've called it enhanced usual care, because we actually do some education and capacity building around supporting screening for gestational diabetes. As I mentioned at the beginning, sometimes the reason why they don't seem to have much gestational diabetes is because they never do any screening for it. And that did seem to be the situation in the centres where we're working. So we have some education around that to try and improve there. And this is a picture of a primary healthcare centre. Okay, so how are we going? Sort of coming to the end of my sort of talk here, you'll be pleased to know that. So we commenced recruitment in June last year. We were slightly delayed because of the bad COVID experience in India the year before, but we were pleased to get underway. We've trained all the healthcare workers in how to use the app, and everyone has all the equipment and everyone's up and running. And so far, we're at sort of 2,000 women out of our 3,500 targets. So we're really going very well with recruitment. So watch this space, and we're hoping to, I think, complete recruitment certainly by the end of this year, and then, as I say, we'll have another year run through as those women get to the end of their pregnancy. So hopefully we will develop some evidence here. So in conclusion, I guess, if you're going to take anything away from this talk this morning, just to be aware that some of these conditions that develop during pregnancy can have lifelong consequences for women. And remember, for many young women, pregnancy care and postnatal care is probably one of the few interactions they're going to have with the formal health system. So really, there is an opportunity for prevention here. But our current postnatal screening really focuses only on immediate pregnancy complications and the baby, missing, I believe, an important opportunity to screen, educate, and engage women about their health. And there could be a role for digital tools to overcome things like health workers and skills shortages, particularly in rural areas, but this is not limited to rural areas, but also to make sure that there is a quality of care, a minimum standard of quality of care that's delivered to everyone equitably, and bridge this gap we have around the world between maternity care services and non-communicable disease prevention services and primary care. So I'll stop there and just finally sort of acknowledge, obviously, this work is requires a big team to get it happening, and we have a great team in India and the UK and Australia supporting this. And I've listed some of the people there, but more you can see in the pictures, and obviously all the health workers and women who are participating. It's wonderful. So thank you. I will stop sharing there now, if I can work out with the technical things how to do it. There we go. Thank you. So great. Oh.
Fantastic. And certainly I have lots of questions, but we're going to move briefly on to Nicole, who will add the mental health dimension to the work that you've been describing. Nicole, over to you.
Thank you, Christine. Hi, everyone. Can you see my screen?
Yes.
Okay, great. Now I just need to figure out how to move this bit away so I don't see that top line. Okay, so I'm just going to quickly talk about something that is added to the program that Jane has presented. So my name is Nicole Votruba. I am an honorary fellow of the George Institute for Global Health UK, and I'm a senior research fellow at the University of Oxford, working with Jane in the Department of Women's and Reproductive Health. And for the SMARThealth Pregnancy study, I'm leading the development of an intervention to address women's mental health. So in addition to the physical aspects that you've heard from Jane, there's also, of course, the mental health dimension. And I'm going to just briefly explain to you what that involves and what we're looking at. So the PRAM Pregnancy and Mental Health Study is a scientific research study in rural India, and we're looking at the same states of Telangana and Haryana. It's led by the George Institute and the University of Oxford, and we're looking to understand what women who are pregnant and 1 year after birth need for their mental health. So what are their needs in terms of mental health? How do they understand mental health? How does the community understand mental health? And how do people around them, the health workers, understand it, and where do they see the need to address it? And based on that, what we find there, we then develop an intervention to support the women in their mental health during pregnancy and in the year after birth. So as you already heard, this is linked to the SMARThealth Pregnancy program, so I won't say much on this, but it's integrated. And so the PRAM program is envisaged to be conducted in 3 phases. So we have roughly 3 years. In 2022, we started with phase 1, the formative and intervention development. So what that entailed was, and this is what I'm going to be talking, so we're still in that program phase, we're coming to the end of that. And in fact, I'm just about to head out in an hour to the airport to go to India to complete this part of the phase. After this phase, so I'll be talking now about this phase, but we'll also be, after the development, doing some pilot testing and then some knowledge transfer and future work. And so what we are doing is essentially trying to understand what is the problem in that community in India. And we know from mostly high-income country data that many women experience changes in their mental health when they're pregnant or after birth, so it's a high-risk period. We know that 1 in 5 women globally will experience a mental health condition during pregnancy or in the year after birth, so that perinatal period. And we do know that poor mental health, as with the physical health risks that Jane has just outlined, can negatively affect women's health, so physical health, and the well-being of their babies and families, and not just in the perinatal phase, but it increases the risks for chronic disease, it increases the risks for later mental health risk, and vice versa. So if there's a pre-existing mental health risk, that also increases the risk. And if these mental health problems are left untreated, they can become severe and chronic and remain. So it's a critical time to have an intervention. And so what we did, because essentially we don't know much, we don't have much research from India and from those, particularly from those rural Indian areas where we're doing the SMARThealth Pregnancy study. So we started talking to the ASHAs. So here you see the ASHAs, those are the community health workers, the ladies in the lovely white and blue dresses. And we went to these centers and spoke to these women. So in the front, with the dark, nice hair, you see the women who are pregnant, and they told us, and we talked to them and tried to understand what is the problem, how do they see mental health, what are the problems that affect them, and we sort of tried to gather some risk factors that women are experiencing. So for instance, very young pregnancies, poverty, gender discriminations, if they had difficult birth experiences, poor nutrition, which is a factor that all these factors do affect women in rural India, low education, if they have pre-existing health conditions, little or no social support, so family structures are difficult, disasters, gender-based violence, so domestic violence or conflict, unwanted pregnancy, not having a say in the pregnancy, not being able to give birth, or substance use like alcohol or any other substance uses. And what helps women in their mental health is strong social support, having caring families, friends, and community, having someone to talk to, opportunities for generating income, so avoiding poverty and being able to pay for essentials, a positive childbirth experience, so being as a woman feeling informed and able to make decisions, educational opportunities, so attending and completing schooling, learning, increasing their educational knowledge, and high quality maternal healthcare services, so empathetic, competent healthcare providers who treat women with respect and dignity. And so we talked to women in these conversations. We had focus groups, so we brought them together from different villages. And these women with their babies that you can see there were some of the women who had experienced challenging mental health episodes during their pregnancies. And we gathered and captured qualitative data there. And so, for instance, one of the themes that came out of the data was a preference for boy child. So still, it's an ongoing issue. It's very known, and there's interventions by the government against this, but still families, women across India do prefer a male heir to be born. So this quote that I've posted here is from the women or healthcare workers, and they said, if she delivers a baby girl, they will not care about her. If she delivers a baby boy, they will celebrate her. So this affects women, this child sex preference affects women and families throughout. It affects their health, it affects their nutritional value that they get. So if a woman, as long as a woman is assumed to give birth to a boy, she will get more nutrition, there's more feeding, there's more caring that comes into, and often, I mean, generally, of course, there's exceptions, but generally this is seen throughout the data and throughout what women and families and the healthcare workers say. And if she gives birth, then say repeatedly to girls, that can even aggravate the difficulties. And so we see that, women struggle with this, and they perceive this really as a mental health care or a mental health burden. This can really develop anxiety. We spoke to some other women in other villages, and another theme that came out there was domestic violence. So it seems so prevalent, and so many women talk about domestic violence in such a normal way that it was quite shocking to someone coming from a Western context where it's not so prevalent. And I'm fortunate enough to not, have these experiences, but it came out from so many women. And they said, for instance, in this quote, when we are pregnant and still he doesn't listen to us, we get upset because of the extra burden of carrying the baby, and being in with an abusive husband is so much stress. We think that it would have been better if we were unmarried rather than suffering like this. So when I coded, or when I worked on this data and I read this, I was really shocked and sad to see what unfortunately so many women are going through, and how massive the burden must be to experience this. And we talked here, you see some family members, also carers, older women who have cared for women with mental health problems. And one of the quotes, or one of the themes that came out here, is nutritional deficiency. So women not being given access to food, or not having access to food, and having poverty. So experiencing poverty. And so these women, one of the quotes was, she could not tell anything on that side, neither could she care. Small kids, they did not even have food to eat. So she did not tell anything on that side means what it meant to say is, like, she couldn't talk about her emotional experiences, essentially because there was so much poverty that, she had to, that was so burdensome, and that affected her mental health, or women's mental health, quite widely. And here you can see the ANMs, the auxiliary nurse midwife. So in the red sari here with children. So they also teach, the teacher in the back, and an ASHA community health worker in the front. And they are sort of the centers, that they're part of the health centers. They take care of they see the kids, they see the women come there also for food once a day when they're pregnant. And one of the themes that came up there when we tried to explore, okay, is there any health provision? Are there any mental health services for these women? Who cares about them? And these ASHAs and ANMs and you know, the women who give healthcare to these women, they do talk to them and they try to provide mental health support, but they don't really have a lot of training or any training really that is provided. So when we asked, where do these pregnant women with mental health problems get help? Will they get any help? The response was they don't get any help. So that's really most of the times, when we're talking here professional help, they do get support by these health workers as much as possible, but there is a lack of mental health professional care and accessible care and available care. And so the challenges that these women face is most women with mental health problems do not receive formal support through the health system. They have families and communities and the healthcare workers that provide it. There's no and very limited mental health services available in rural India. Often the women do not share their mental health problems, seek help because they feel ashamed. So that's the whole problem around stigma. They don't talk about it. Families don't talk about it. And difficulties exist for women in accessing mental health care. So often these villages are very remote. It's very difficult to even get help, even for severer cases. Or because of poverty, not having the funds to access care or access transport. And it is not known how women can best be supported in their mental health during pregnancy and after birth in the communities. So hopefully with the PRAM program, we're aiming to develop this. We're asking these women and we're trying to develop an intervention that can then support women in their mental health during pregnancy and after childbirth in rural India. And what we're thinking of and sort of doing now when I go to India in the next few weeks is to find out what type of intervention would work. Is it a community? So is it bringing women together to talk about this, to teach them about mental health, to teach them how to take care of their mental health? Do we need to involve the families? Do we need to involve the husbands? Do we need to talk about domestic violence and how to reduce it together with partners in India that are there? You know, some NGOs are existing there and they're providing help. So how can we work together with them? Would this help the women? How can we improve access to nutrition for women? How can we work with the gender and sex bias for children that still exists? And how can we make a girl child less burdensome experience for women and more acceptable experience with partners who have been working on this for a long time? This is the idea that the PRAM study is aiming to do, and all that is happening within the SMARThealth Pregnancy program. And the aim is to have a happy and healthy mother and a happy and healthy baby for the communities and support these women in an equity-based approach. Yeah, if you want to hear more about the PRAM study, please do contact me or Jane. And that was all from me. Here's the team in the background again.
Nicole, thank you. That really adds to the presentation that Jane gave. And there are some, please put your questions in chat. There are some appearing already. I have lots, but I think I should probably let others, but I'll just say some of the things that really struck me as of real interest. I think it's always interesting to share experiences of training community health workers. I think that's such an interesting area. So if there were time, I'd ask for more on that. I think I've already told Jane that in my early career as a midwife, I was told that gestational diabetes is something that some women get during pregnancy and then they get over it. While I think that view has changed a lot, I think Jane's figures from the UK show even in a country like this with our health system, there's still much more to do. And I think that for C3, I think your point about bridging the gap between maternal and child health and NCDs is really important. If we look at the Millennium Development Goals, how maternal and child health was the one that really didn't succeed, and yet people weren't as shocked as I think they should have been in achieving those targets. But also I think I've always believed, and I was pleased to hear Jane say that what an opportunity for prevention maternal care presents, because it's a period of time, because also, as you pointed out, some people do it again, so you can repeat it. And yet I've seen a lot of pushback from midwives saying, oh, but women are so burdened by everything they have to face. You can't add prevention onto that. So there's a number of things. Alistair Fisher, who we know, I'm delighted to welcome again to one of our programs, has asked a large number of questions. Alistair, can you restrict yourself to one initially and tell Jane or Nicole where you'd like to target it, and then we'll move on to others. As I think we said at the beginning, the event's recorded, so there's an opportunity, and Jane has kindly already shared one of her references in response to a request. Alistair, one question from you, and we'll come back if there aren't any others, but I think there are. I think you're muted.
Yes, I know. I'm not muted anymore. No, well, I was just, it was just scattergun stuff that I thought could be interesting because, and I don't know whether anyone's any better than the other, but the one thing that isn't in among there is that I noticed that Jane didn't say anything about husbands or fathers if they weren't husbands, and in her talk, and yet it seems as though that might be key to a large number of the problems that are in mental health. So it looks as though the two, it looked to me as if they might not be joined up enough, if that's the case.
Interesting comment, and leave Jane and possibly Nicole as well to answer, and then I'll invite Andy Jones next. Jane.
Yeah, thank you, Alistair, for that question. I mean, I think, you know, just given the interest of time and things, I had sort of, it's quite a high level sort of summary that I presented today on what's happening. I mean, I think this was part of the reason for bringing Nicole on board and having a deeper dive into sort of the social context of what people's lives are like, you know, here, because obviously it's fine for us to say, oh yeah, people should eat this sort of diet, or they should, you know, take this tablet. But, you know, the reasons why people don't do these things are not necessarily because of ignorance or because they don't want to. It can be a lot of other barriers in the family and the socioeconomic situation. So, you know, that is exactly right. And alongside the SMARThealth Pregnancy main big trial, we've got a very detailed process analysis to try and dive into some of those drivers that make things more or less likely to succeed in settings. I mean, I think, you know, it can be easy to just say, oh, it's all just a bit too hard and we're never going to make any difference. And you know, my attitude is, you know, even if we, you know, make a slight breakthrough, that's actually, you know, better than no breakthrough, because at the moment, as I say, there's no evidence here. But I think we need to understand, yeah, a little bit more around you know, what the context specifically as to what may or may not, you know, allow things to be scaled. So I think the role of men partners is very important. However, you know, because of the huge gender issues in India, I really want to have a project which focuses on women and centers them as well, and gives them agency in what they're, you know, doing. So there's sort of dual motivations there.
Thanks. Andy, do you want to ask your question, or Nicole?
Yep.
Please do.
Indeed. Yeah, I mean, I thought, I mean, great presentations, and I'm really impressed with your methodologies, you know, in what's I'm sure quite a challenging setting to do this sort of work. You know, I thought, you know, you've seemed to tick every box there. I was just interested, sort of, you know, obviously pending the outcome of the definitive trial in terms of the, you know, the effect of the program, around sort of future scaling up of this. And I'm kind of interested in, you know, what your sort of perceptions of the challenges are, but also do you have the sort of level of political buy-in in order to be able to sort of, you know, for this thing to be, you know, delivered at scale in the future?
Yeah, that is an excellent question, and something which, you know, we talk about a lot, you know, because this is obviously the, you know, where a lot of great interventions fall flat, is because, you know, academics like me do a nice trial and then it's like, oh, well, so what, you know, no one's picked it up. You know, how do we actually get the ear of policymakers? And you know, this is where actually working with the George Institute as a partner, you know, based in India, with, you know, really strong connections to government, makes a difference. And it's actually the reason why we moved from working in Andhra Pradesh into Telangana, because we felt there was more sort of fertile soil there for this sort of intervention. That they have a very progressive health minister, and, you know, they were really, yeah, we want this, you know, let's go for it. And so you do have to, you know, grow towards the light a bit. And I guess if you can get some of those partnerships established, then hopefully, you know, as things roll out and people can see success, that will help, you know, nudge some of the places where there's more resistance going on in that direction. The other thing is, you know, the digital health market, if any of you are working in it, it's extremely crowded, and obviously India is a tech capital sort of thing, so there's lots of stuff going on. And I think as an academic, I'm not particularly wedded to this app, you know, sort of thing. I don't have shares in it or anything like that. What I'm trying to show is more a concept of how, you know, if you are using a pregnancy app, which many places are, couldn't you just extend it into the postnatal period, and couldn't you just do some more screening on these high risk conditions so we can bridge that gap? So for me, yeah, I'd love to see our app sort of scaled and used, but I think, well, not just the app, the whole program. But I think, you know, I'm also realistic about what is possible, and you know, not sort of, as I say, in this for profit or anything like that. I mean it just to sort of prove a point, if you like. So, but that implementation piece is, yeah, it's something that we are working on. And as I say, the detail, so the process analysis that we're working on, part of that is actually looking at the sort of, you know, what is going to be needed for scale up. So we do have a sort of detailed economic analysis going along with this, because I think we're gonna have to make an economic case if we want investment by governments particularly. But yeah, this is a challenge. You know, I'm not saying this is an easy thing or we've got it sorted, but it is something that we're working on.
Great. And having had this discussion about the relative balance between men and women, I've managed to let two men ask questions and slipped over a question from a woman. So my apologies to Sarah Deakin, who's not able to speak from where she is, but her question's on the chats, and she's saying that she's working on the Start for Life programme and is wondering about the inclusion of the community health worker idea and the SMARThealth app in the programme. And Jane, Nicole, do you think this could be replicated in a higher income country like England? And while it's certainly not the sole purpose of our international seminars, certainly learning from experiences from very different places is certainly one of the things behind our idea for these seminars. So can you tell Sarah whether she should be excited about its possibilities in England, I think?
Yeah, I think this is a great question, and definitely yes. I mean, I'm all for sort of learning. I mean, you know, learning from wherever around the world. If evidence is generated that looks effective, why not? I mean, we have a big problem here, as I alluded to, with follow-up after these women who develop high-risk pregnancy conditions in the UK. And yes, I mean, the skills level required to do this screening is pretty basic. I mean, these community health workers we're working with in India have the equivalent up to a grade 10 education. So, you know, it's not like you have to have a, you know, a degree or anything like that to be able to do this. And being supported by the digital tools, I think is a great way forward. And, you know, I would be really open to that. I mean, whenever I've suggested this before to people working with, you know, sort of healthcare support workers and home visitors and things in the UK, the answer is like, oh, they're too overburdened and, you know, it could never happen here. But I think, again, you know, that's maybe a little bit shutting the door before things have actually been assessed, or actually, you know, looking at what would the burden be, you know, how many are we to insist. So I think those conversations need to happen. And yeah, I'd be really keen to, you know, open that up, and especially this is a good way to be reaching women who are perhaps more marginalized from the mainstream health system, living in areas where it's hard to get a GP appointment, which is probably for most of us. But you can imagine, you know, I mean, a lot of the women who we're seeing with, especially with diabetes in pregnancy and also hypertension, are not from you know, white middle class backgrounds. They're from all sorts of different you know, groups, including refugee groups and things in the UK. So yeah, I think definitely there could be a role, and particularly if it's members of their own community who we can, you know, engage to do this screening.
Yeah, I think maybe just to add, in particular for mental health, I think there's a fantastic opportunity there to have this South-North learning, because we think that our model, you know, we try to translate the psychotherapy or whatever model, and simply we don't. I mean, we face similar issues that we have in rural India, essentially. I mean, we don't have the care provision in the UK that we need for the people, and particularly, like Jane said, marginalized communities. Women who came, immigrants communities who may have come a few generations earlier, are sort of a lot living in their own communities. So they have their sub-communities that they stay in, and the traditions are living on. So I personally would be very interested to see how this could be replicated. And I know some colleagues in South London, for instance, and North London are doing similar studies to find out if, I don't know, in specific, I don't know, Black communities or South Asian communities, models like these can be replicated or can be done. And we're sort of trying to find out what works in which specific setting and in which community. And I think also for, yeah, potentially also for the NHS, we could learn from that, and having a group setting for mental health would be efficient.
Yeah, we at C3 are doing some work at the moment with nurses from ethnic minority backgrounds to reach into their communities as a way of reaching people in a more acceptable way. And of course, in the UK, we've got the shocking figures of, I think, 4 times the maternal mortality in Black women than white women in this country, which is just so shocking. We have a question, and I think probably have to be the last, from Ataya, if I've pronounced it well. Please come off mute and ask your question.
Thanks. I was enjoying this discussion, and a thought came in my mind as to how can we create a digitally inclusive environment, particularly in low middle income settings, and what could be the strategies where the digital apps are not accessible, and how we can resolve and improve the access. Thanks very much.
Yeah, this is another very good question about equity and not creating a digital divide. I mean, I think the way that we're using this system is that we're providing the community health workers with a digital tool. So at the moment, it's a tablet device, an Android tablet, but it could be an Android smartphone. And actually, in many states in India, the government are already providing the community health workers with those devices, and so hopefully that there should be some. At the health worker level, there should be access. It was important that the tool is actually available online and offline, because the sort of reception for mobile phones can be a bit patchy in some areas we go to. We are sort of exploring, you know, options for, you know, contacting directly the women, you know, giving them public health messages or reminders and things. But that's when you start to really run into problems that, whilst there may be a mobile phone in the household, it might not be owned by the woman. And so who is actually getting those messages, and are they getting to the right target? I mean, I think when you look at the pace of you know, the spread of mobile phones across the planet, it is pretty impressive. And there's not many areas that are totally untouched by digital access, mobile phone access these days, is it? So I think there are options, but we have developed this for an Indian context where you know, there is capacity for, you know, a smartphone rather than a you know, just an SMS service, which you may have to do in other areas if the tech wasn't there. But yeah, but good question. But it is something I think, again, we'll be looking at in our main trial to check, you know, who did we reach and who did we miss, sort of thing, with this this system, and try and think of strategies around it.
Yeah, I don't know whether it's still the case, that frightening statistic about there being more mobile phones than toilets in India.
I wouldn't be surprised.
I think we're doing some training at the moment, online training with nurses in Africa on oral health, and very much had to translate it to WhatsApp because that's what they're all comfortable and able to use because of the access issues. But equally, I think sometimes we underestimate the impact just of using digital has. And my colleague Elizabeth, who's on the call now, did some work with Bangladeshi women in I think Tower Hamlets, and they wanted a certificate to add to their CV that they'd been using this digital app, and it made us think of the, if you like, the side benefits to women, particularly women, but not exclusively, with low access to technology, and the impact and the pride they had in showing that they could use it. I'm conscious of the time. I think lots of us could talk forever. I think we've made some links and some understandings that we can follow up, and I'd really like to say a very big thank you to Jane and to Nicole for presenting such interesting work, and I hope that we'll be able to follow as it develops and rolls out. Our thanks to the George Institute for their help in working with us, with two of their colleagues, and we will make sure you will know the date, because I can't remember it, of our next international seminar in May, which also be working with the George Institute and with Bruce Neal and the work he's done on salt particularly. So thank you all for joining. Look forward to seeing you at a future event, and a big thank you to Jane and Nicole and to the George Institute for working with us. Thank you, everybody. Bye.